Okay, great. All right, so welcome. Thank you for attending. This is head injuries 90, 99, and we'll talk about that in just a minute. For those of you who don't know me, my name is John Jardine. I'm attending at Our Lady of Fatima Hospital, and we'll just go ahead and get started. So first, some housekeeping items. Certainly to thank you again for joining on, and thanks for taking the time to join on to rounds. I do appreciate the great turnouts we've been having, and again, thanks for your interest in all this. For those of you that transport to Our Lady of Fatima or Roger Williams Medical Center, we're starting something now called an EMS timeout. And that is when you guys come in with a patient, we want the staff to sort of stop and do a timeout and then greet you at the bedside so that we all get the story at the same time. That includes the attendings, the nurses, the techs, whoever else is available at the time. And hopefully we can make that happen. So again, for those of you that go to Fatima or Roger Williams, expect this to happen. Keep an eye out for this, and we certainly want to make sure that it's happening as much as possible. So let us know about that. Secondly, if you haven't yet seen, we have an EMS newsletter. Our first issue is out right now. There's some interesting information there about the hospitals, the Charter Care Health Partners system. There's a section in there about an EKG of the month, which you can kind of learn a little bit about something there. And then there's a schedule for EMS week. As you guys probably know, EMS week is coming up next week. And there's a schedule of events in the EMS newsletter, including some barbecues at both sites, coffee trucks, ice cream trucks, etc. So again, some good stuff happening there. Rounds topics for rounds coming up. Next scheduled rounds is on June 9th. And I've been asked to do a review of stroke and the stroke protocols as part of our, I guess, as Charter Care's commitment to being a stroke center. So June 9th, the next topic will be about stroke. And I'll probably mention that at the end as well. And then, as we continue at Charter Care, both Fatima and Roger Williams Medical Center, we really want to know what we can do for you. So, rounds and things like the EMS timeout and the newsletter, again, are all sort of geared towards, our commitment to a great relationship with EMS. And we certainly hope that continues. So getting into the topic, this is a guy called Phineas Gage, and I don't know if anybody has ever heard of him or knows him, but Phineas Gage was a railroad worker back in the 1800s, and they were putting in a rail line, and they had to cut through some rock. And what they did was they drilled holes in the rock, and then they poured black powder down the holes and tamped it down into the hole, and then exploded the rock to break away the rock. And what happened to Phineas here is that when he tamped down his a hole in the rock with the black powder, he caused a spark which made the powder explode. And it sent that rod that he's holding in his hand, it sent it up through his head. And you can see there's a monument there at the site where it happened in Pennsylvania. And you can see how that rod went up and right through his head. So what happened was that, Phineas was at first a likable guy, a good worker, hard worker. And after this happened, they noticed that he was, sort of mean and ornery and no longer the worker that he was before. And we learned a lot about brain anatomy from an event like this. We knew that, what happened is that, we know now it wiped out his frontal cortex, which is responsible for his personality, et cetera. And that's really what happened to Phineas. So, but again, through these tragedies, we learned a lot. So this was how we learned about the initial anatomy. So if you look at the National Registry, the education standards at the paramedic level, what do we need to know about neurologic emergencies? To what standard are we going to be required to teach? So first, we're going to talk about the incidents, and we'll talk a little bit about that. Cauda-equina syndrome, nerve root injury, peripheral nerve injury, traumatic brain injury is really what our topic is tonight, spinal cord injury, and then spinal shock. So these are the areas that you're expected to kind of know about, again, as the educational standard for National Registry. So we're going to cover traumatic brain injury tonight. So the incidence, and you can see this was reported to the CDC back in 2003. So this is real, at this point, probably old information, but just to give you an idea of what's happening with the incidence of brain injury. So 1.4 million people sustained a traumatic brain injury annually. Again, this is a little bit older data, but the sort of the problems are still the same, right? So it doesn't include people who are not diagnosed. It doesn't include military statistics, and it doesn't include sports-related statistics. So there are lots of people that have brain injuries that we just don't either know about or diagnose or see, et cetera. And again, this is an old number, but $56 billion in direct and indirect costs. So I'm sure that number has grown. 50,000 die annually, and approximately 100,000 have long-term disability from brain injury. So it's kind of a silent epidemic. We know how many people die from it because that's, that can be recorded. We know how many people are hospitalized as a result of brain injuries. We get an idea of how many emergency department visits there are, but we really don't know how many brain injuries are occurring because, again, some people just don't come to care or, certainly don't get diagnosed, in the military, et cetera. So we don't know the real epidemic that this is. So what are some of the causes of traumatic brain injury? Well, certainly vehicle crashes account for, you can see, half of brain injury. Sports and recreation, and we'll talk a little bit about that, about 10%. Firearms, you see falls, 21%. That's next to vehicle crashes, that's probably the biggest. And then other, obviously there's some other reasons for brain injury. But again, we'll talk about some of the specific injuries. So we're going to start simply, and we'll, go to the textbook, right? We'll just start talking about the brain. This used to be an entertaining slide, and now it's rather, Dr. Seuss has been, cast away. So I probably have to get rid of this slide because it is Dr. Seuss. But anyway, we're going to start simply. We're going to start talking about the brain first and how, the normal part of the brain, and then how things go awry. So first, the skull. Obviously, the skull is the case that the brain sits in, and you can see on the side, there's the frontal bone, there's the parietal bone, the occipital bone, the temporal bone on the side, and then some other smaller bones that make up the skull. And obviously, you can see from the outside that it's pretty well-rounded, pretty smooth on the outside. But if you look down inside the skull, you can see there are lots of bony prominences and sharp areas, and et cetera. So it's a little bit rougher on the inside. When we talk about skull fractures, and we'll talk about these again, but the first and probably certainly the most common skull fracture is what we call a linear skull fracture, and that's just a crack in the skull, just a sort of a linear crack. And that's about 80% of all skull fractures. There's really no gross physical signs. It usually doesn't cause much issue, but you may certainly see it on imaging if you do imaging. Next is the depressed skull fracture. This results from a high energy direct trauma where a portion of the skull bone is actually depressed, and this is going to actually present with neurologic signs as the skull is pressing on a particular part of the brain, and certainly will give you neurologic signs depending on what part of the brain is affected. Basilar skull fractures, and we'll talk more about these as we get into this, but it's usually from a diffuse impact to the head. Some signs include, you may see CSF drainage as it may leak out, raccoon eyes and battle signs. And again, we'll talk about these in detail as we go on, but these are just some of the sort of skull fractures as you go from the outside in. And then of course, open skull fracture, which is obviously carries a high mortality rate. This is when you have severe force to the skull, opening the skull and exposing brain tissue and sometimes leaking out brain tissue. And this, again, this obviously has a high mortality rate. So let's look at the brain inside, and you can see that the brain inside the skull, there's really not a heck of a lot of room in there, right? There's not a lot of room for anything else to be in there. So the brain fits tightly, and there is the meninges, which lines the brain and spinal cord. And if we look at that anatomy, again, starting from the outside, working our way in, we get the skull, and then we come to the well, first the scalp, the skin over the skull, then the skull, and then there's the dura and arachnoid and pia matter, which are the meninges, right? But if we start from the skull, on the outside of the dura is what we call, or is the epidural space, or outside of the dura. So that's the epidural space. And obviously that's going to be important when we talk about bleeding, et cetera. And then there's the dura mater itself. And then below the dura is the subdural space. Okay, that's another potential space there. The arachnoid kind of looks like a spider web, if you will. And then of course, under the arachnoid is the subarachnoid space, in which flows the cerebrospinal fluid. And then finally the pia mater, and then you get to brain tissue itself. So again, it's kind of important to know where these structures lie, because when we talk about abnormalities or bleeding or trauma, it's important to know, sort of what the normal is. So the brain itself obviously is divided into different sections. There are different sections of the brain do different things, and we all know that, and we'll talk about that probably next month when we talk about stroke. But certainly there are different areas that are responsible for different functions. And if you look at this is a cross section of the brain, and this is the diagram on the bottom is something that we call the homunculus. And this is just a sort of a roadmap of where things are happening on the brain. And you can see, down here in the speech center of the brain, if you have a lesion or a trauma or stroke there, it's going to knock out the speech center, here for the hand, here for the foot, et cetera. So again, it's important to know where all of these things are located, because we can then, figure out what kind of neurologic findings we're going to find when we have either trauma or injury to the brain. So don't forget that the central nervous system is the brain and the spinal cord together. So the spinal cord, again, runs down through the spinal canal down to the level of about L1, but together these are the central nervous system. And then beyond that is what we call the peripheral nervous system, and it's broken into the autonomic or somatic. And again, we're not going to get into too much detail about the nervous system, but just suffice it to say that there are, after the central nervous system come the peripheral nerves, and these are how we're going to test for nerve function. So the neurologic exam itself, the objectives of the neurologic exam is certainly to identify any abnormality in the nervous system, right? So obviously that's what we're looking for. Where's the abnormality? And we're going to differentiate, is it something that's peripheral or is it something that's central? So is it something in the peripheral nerves or is it in the central nervous system, the brain or spinal cord? Going to establish internal consistency, is the patient actually cooperating with the exam, or do we know that the patient is cooperating with our, when you ask them to move and et cetera, et cetera. And then there are, certain variants of normal that we have to know about when we do a good neuro exam. So to start with the neuro exam, you first look at the patient's general appearance. That includes posture, motor activity, of course, vital signs or meningeal signs, how they're holding themselves. Are they slumped to the left? Are they, is their arm kind of shaking? Things like that. So again, that's part of your general exam when you first see a patient. A mini mental status exam is a way to test cognitive function, and certainly somebody who has dementia or any other cognitive defects will sort of flag on the mini mental status exam. This is when you ask people to remember, certain items and then repeat them back to you, or, count back from 100, things like that. Cranial nerves, we'll talk about the cranial nerve exam. There are, 12 pairs of cranial nerves. The motor system, we're going to test the motor system. The sensory system, we're going to test that. Reflexes are part of the neuro exam. Coordination, gait, Romberg's test. These are all ways to test certainly the cerebellum, which is responsible for coordination, gait, and muscle movements. And then what if someone's in a coma? How do we examine somebody who's in a coma who can't participate with the exam? And we'll talk about some findings that way as well. So cranial nerves, again, there are 12 pairs of cranial nerves, and there are certainly a lot of mnemonics to remember the cranial nerves, but you know, I'll leave that up to you guys. But certainly, again, 12 cranial nerves, and they come out from the, you know, the brain stem and the underside of the brain, and they are you know, functioning, you know, sort of in the background without us even knowing about it. But again, there are ways to test for the cranial nerves and to test brain function. If you look at the cranial nerves, you look at, again, there's 12 of them, but 1/3 of them, 4 of them involve the eyes. So just by doing a good eye exam, you can get, you know, you get 4 of your 12 cranial nerves on exam. So let's look at the eye exam. Cranial nerve 2 is the optic nerve, and that's responsible for vision and visual fields. Certainly you can test somebody's vision, test their visual fields, you know, can you see my fingers coming in from the sides, etc. Cranial nerve 3 is the oculomotor nerve. This keeps the eyelid open. So the, you know, the lids are open, and it constricts the pupil. So this is the nerve that's responsible for pupillary constriction. Cranial nerve 4 is the trochlear nerve, and that is a sort of the muscle goes through a pulley system to cause rotational eye movements. And you can see, you know, again, by testing eye movements, you can test that nerve, as well as the cranial nerve 6 or abducens nerve that moves the eye laterally. So again, by doing a good eye exam, you get 4 of the 12 cranial nerves. So let's talk about the eye exam, and we'll talk more certainly about a pupil exam, but, you know, a normal on the left is, you know, a normal pupil exam is pupil, we say that the pupils are equal, round, and reactive to light and accommodation, right? So that's a normal exam. Whereas on the right, you see what could be abnormal is if we see what we call a blown pupil. And what is a blown pupil? It's a dilated pupil on one side, or sometimes both sides. And that's typically caused by compression on that oculomotor nerve. So say you have something like a bleeding, like a subdural hematoma that's causing pressure on the brain is then caused to herniate down through the foramen magnum. And then you can see here that as the brain is herniating, it's pinching against the oculomotor nerve, which causes the pupil on that side to be dilated, or what we call a blown pupil. So again, we're going to talk more about the pupil exam, but this is to say how we're testing cranial nerves. And then again, with pupils, there is something called anisocoria, which, you know, of course, throws a monkey wrench in the whole thing, is that, you know, up to 10% of the population have unequally sized pupils. So certainly if somebody is awake and alert and you can ask them, you know, is your right pupil always bigger than your left pupil, et cetera, you know, that could be certainly helpful, you know, to have somebody participating with the exam. Ptosis is when the eyelid sort of droops, right? I tell you that the oculomotor nerve keeps the eyelid open. And so if the oculomotor nerve is not functioning, then the eyelid is going to droop, and that's what we call ptosis. Okay, going on with the eye exam again, on a normal exam, when we test the extraocular motions, we say the extraocular motions are intact. You know, we have them look up, look down, right, left. If at any time when we look right or left, if one eye moves and the other eye doesn't, this is what we call disconjugate gaze. And again, this is an abnormality in the cranial nerve exam. And nystagmus is when the eyes kind of beat, if you will, or oscillate. So when you have them look to either the left or the right and the eyes kind of jiggle a little bit, that can be an abnormality on your neuro exam. So these are the dermatomes, and all of when we talk about the peripheral nervous system, all of the nerves that come out of the spinal cord and you know, innervate the parts of the body are sort of mapped out in this way. This is a dermatome chart. It shows where each nerve, you know, that comes out of the spinal cord is responsible for a particular part of the body. And again, this becomes helpful when we're doing an exam to find, you know, where the problem is with the nervous system or the, you know, the abnormality. Motor exam, again, I said the motor exam was part of the neurologic exam, and this again involves body positioning, involuntary movements, muscle tone, muscle strength. And this is how we gauge strength, or certainly define strength, is a 0 to 5 scale. Of course, 0 is no muscle contraction at all. 5 is, a normal exam where they can overcome resistance. If you don't remember the muscle strength scale, certainly you can describe what's happening. Like say like number 2, they move when gravity is eliminated. In other words, somebody may be able to move their leg back and forth on the stretcher, but then can't lift it off the stretcher. So they do have some motor activity, but certainly not normal motor activity. So again, this is just a way to gauge muscle strength so that we can, sort of communicate with our colleagues on what is happening with the motor exam. So this is a quick a motor exam, again, based on the dermatomes. If you look at the dermatome chart, you can see again where each of the nerves innervate which muscles. So just by having somebody, flex their arms, the biceps flexions, that's C5, C6. Then extend your arms, that's C6, C7. Flex the fingers is C8. Fan the fingers, that's T1. Raise your leg, that's L2, 3. Bring your foot up towards you, that's L4, 5, and then, press on the gas or push your toes away, and that's S1, 1, 2. So just a real quick exam for somebody, flex your arms, extend your arms, flex your fingers, extend, raise your leg, and then, toes up towards you, and then press on the gas is a quick way to do a quick motor exam for all of the nerves. Sensory exam is, again, you use the same dermatome map, but this involves, pain sensation, light touch sensation, do you feel me touching one side or the other? Position sense, is your finger pointing up or down, sort of thing. And the importance here is symmetry, right? Is it the same on the right as it is on the left? Do you feel the same on the right as you do on the left, et cetera? And that's an important part of the sensory exam. Again, this is a quick, quick exam for sensation. You can see that this exam starts at C5 because, we say C3, 4, 5, keep a man alive, right? If there's injury to the cervical 3, 4, 5, then, certainly somebody could be in cardiac arrest or at least not, not breathing. So again, the lateral part of the arm is C5, the medial part of the arm, T1. And again, you can see this on the chart. The thumb is C6, middle finger C7, pinky C8. And this is where, it kind of becomes important that there's these sort of landmark dermatomes that we all should know. The nipple level is T4, so that's thoracic 4. The umbilicus or belly button is T10 or thoracic 10. So again, if you have somebody with a spinal injury or a back injury and they say, I can't feel anything from, the nipple level down, or I can't feel anything from my belly button down, you have a good way of sort of locating where that problem or lesion is. So the upper part of the leg, you can see on the dermatome chart, is L2. The medial upper leg is L3. The medial lower leg is L4. Medial lateral lower leg is L5. And then the sole of the foot is S1. This becomes important too when you're talking to people with back pain and you say, I have pain in my back and it kind of radiates into my leg. Does it go all the way down to the foot or does it stop at the knee? And that kind of gives you a hint of where the problem could be with a disc, et cetera. So if the pain only goes down to the knee, then it's like an L3 area. If the pain goes down all the way to the toes, it's L4, L5, and possibly even down to S1. So again, the dermatome charts, if you know the location of the nerves, where they function, where they innervate, then it's a way to sort of map out where the problem is. Reflexes. A reflex is a quick action that happens, and it just is what we call a reflex arc. It goes back and forth to the spinal cord. If we had to wait until the message got all the way up to the brain and then came all the way back down to innervate our muscles, we'd be in big trouble. So the reflex arc, goes from the stretch receptor of the muscle, goes to the spinal cord, and then goes back to the muscle for contraction. And you can see in the picture there, they're showing the reflex hammer, stretching the tendon there, which sends the reflex arc back to the muscle. And again, reflexes are graded on a scale from 0 to 5. 0, no response. In this case, normal is 2, and then you can be hyperreflexic. So the reflexes can be either more exaggerated than normal, and you may define them as brisk or hyperreflexive, or even something we call clonus. And clonus is, you can typically see clonus in the foot. If you sharply dorsiflex the foot and hold it there, you can see sort of a, a quivering of the foot, or a clonic rhythmic pattern of the foot, and that's called clonus. And this is seen sometimes in stroke, seen in MS, seen with spinal cord damage, sometimes with hepatic encephalopathy, and sometimes even with serotonin syndrome. So people who are using SSRIs, the selective serotonin reuptake inhibitors for depression, if they overdose, or sometimes even if they just have an extra dose, you may sometimes see clonus in these folks. But in a sense of trauma or a coma exam, this is certainly indicative of an upper motor neuron problem or a central nervous system problem. The Babinski reflex, this is an abnormal extension and fanning of the toes. And this again indicates an upper motor neuron lesion. You can see on the left that there's the diagram here, a normal response if you strike the bottom of somebody's foot, if you kind of stroke their foot with a pen, or in this case, a reflex hammer, the normal response is to plantar reflex, to kind of want to grip onto that. An abnormal reflex is called the Babinski reflex. And again, it's the upper fanning of the toes, and this is abnormal. The thing to remember about the Babinski reflex is that it's normal in infants and children. So you can see here on this artwork here that the Babinski sort of reaction, the fanning of the toes, is normal in children, and then in the adult, it becomes an abnormal finding. I had a comment last month about art history. So this is a Botticelli painting from the 15th century, and certainly Botticelli is more known for the birth of Venus. And this is a painting that is in the Uffizi Gallery in Florence, Italy. Okay, moving on. Coordination, gait, Romberg's test. I said these are all tests of the cerebellum, which is responsible for muscle coordination. And you can do a test for, which is called dysdiadodokinesia. And that's when you kind of have a patient go back and forth like this and see if they can maintain that. Or what's sometimes easier is the point to point. So you say, point at my finger, point at my nose, point at my finger, point at my nose. And then, again, this is just a test of coordination and a test of the cerebellum. Gait, certainly you can test someone's gait. Romberg's test is you have someone stand at the bedside and close their eyes, and you make sure that they can stand without tipping. Again, it's all a test of the cerebellar function. Okay, coma. So what if someone is in coma and they can't participate with any of our exam? There are certainly things that we can look for when someone is in coma or certainly not responsive. So to be in a coma or in a comatose state, there has to be something wrong in the brainstem level or above, because the brainstem is where something that's called the reticular activating system, and that's what keeps us awake. So a trauma or lesion at the brainstem level or above is gonna cause coma. There are metabolic causes of coma, and we'll talk about that. And then there are structural causes of coma, and we'll talk about that as well. So what are some of the things that you can find on exam? There are some abnormal reflexes that you may see with someone with coma. There is a reflex called the oculocephalic reflex, or doll's eyes, where normally if you turn someone's head side to side, the eyes will sort of track. But someone who is in coma, their eyes will stay in their head and point straight ahead, just like as if they were a doll. So the oculovestibular reflex is something called cold calorics. And if you've ever had cold water put into your ear, you'll know what I'm talking about. It causes what you do is you shoot cold water into someone's ear, and it causes a reflex where the eyes will deviate and cause a little nystagmus. That's a normal reflex. Again, in someone in coma, they may have lost that reflex. So that's a way to know if someone is truly in coma. The corneal reflex is innervated by cranial nerve 5. And that is just touching the cornea with a, light, like a cotton tipped applicator or something like that. The cornea, the normal reflex is to blink. And certainly if someone is in coma or truly unresponsive, then the corneal reflex will be absent. The gag reflex is cranial nerves 9 and 10. Again, someone who is truly in coma will not have, they have lost their gag reflex. And this is a way to test for someone who is in coma. The Babinski sign I talked about, the Babinski, an abnormal Babinski, a fanning of the toes is certainly abnormal, and that indicates an upper motor neuron lesion. And then posturing, certainly decerebrate or decorticate posturing, which we'll talk about that a little bit more coming up. This is the Glasgow Coma Scale, and we're going to talk more about this when we talk about the brain injury itself. But this is, a scale that is a way to communicate someone's alertness or good neural response. And again, this is not something that I don't know if anybody's memorized it. I certainly haven't memorized it. You kind of have to look at it each time, but it gauges what happens with the eye response, a verbal response, and a motor response, and then you give that all a score. And again, we're going to talk more about the Glasgow Coma Scale and how important that is. I found this recently. I thought this was kind of cool because we do see people, you can add this new cell phone use to the Glasgow Coma Scale. So if they're talking while they're on the phone or they're taking a selfie or texting, and you can see, you can give somebody a Glasgow Coma Scale for that. Okay, altered mental status. I did say that there were metabolic reasons and there were other reasons. So this is a good mnemonic for people who are in altered mental status. It's AEIOU TIPS. And again, this is a mnemonic that's good to remember for why somebody would be altered or why somebody would be unresponsive. A, certainly alcohol. We see a bit of that, I would say. And A also stands for ammonia. So people with hepatic failure, hepatic encephalopathy, they have high blood ammonia levels, and that's what causes them to be altered. So A for alcohol and ammonia. E, endocrine. There are a number of endocrine situations, certainly something like hypothyroidism can cause somebody to be altered. And then electrolytes, same thing, right? So dehydration, hyponatremia, hypoglycemia. Again, these can all cause someone to be altered. I, insulin, of course, someone in insulin shock or insulin coma, if they've, if their blood sugar is down because they've taken too much insulin. And then there is of course, I for iatrogenic means that it's something that we have caused. So whether it by medications or some procedure that, we have caused somebody to be altered. O, oxygen, or actually lack of, I guess, would be a better term. If somebody's hypoxic, they can be certainly altered. And of course, opiates, again, which we see, a number of cases of opiates as well. Uremia, we talked about uremia last month when we talked about metabolic acidosis, but uremia can certainly alter somebody's mental status for the same reason. T for trauma, and we'll talk more about that certainly, and temperature, someone who's altered, either extremes of temperature, whether they be hypothermic or hyperthermic, can certainly cause somebody to be altered. I, again, for infection, any of the infections, meningitis, encephalitis, any infection, sepsis even could cause somebody to be altered. P, poisoning, again, think about the toxicologic stuff or other poisons. Or psychogenic as well. It could be something that is, more, certainly not structural, but more psychogenic. S for seizures. Certainly seizures can cause somebody to be altered. Stroke, and again, we'll talk about that next month. Space occupying lesion, tumor, bleeding, whatever, can cause someone to have altered mental status. So again, this is a good mnemonic for some of the reasons someone can be altered. But tonight our focus is going to be really on trauma, causing someone to be altered. And that's what we're going to talk about is the traumatic brain injury. So again, going back to the cranial injury or skull injury, the trauma has to be pretty extreme to cause a fracture in the skull. If you think about it, your skull is pretty hard. I'm sure we've all hit our head at one point or another and realize that it's pretty hard. And obviously it's doing its job to protect the brain, right? We already talked about linear, depressed, open skull fractures. This one adds impaled objects in the skull, which, obviously can cause some problem. The base part of the skull, or the basilar skull, is pretty unprotected. There's a lot of open spaces there, sinuses and mastoid process and things like that, that cause the basal skull to be relatively easier to fracture. So it's, again, just diffuse injury to the head can cause a fracture in the basilar skull. So this is a basilar skull fracture. These are signs of basilar skull fracture. And again, I kind of alluded to this earlier on, but Battle's signs are named after someone named Battle, that they're not meant to be, like they happen in a battle. But anyway, Battle signs are retroauricular ecchymosis. So there's bruising behind the ear. And you can see that on the diagram here. There's some, it's starting to get ecchymotic back here behind the ear over the mastoid process. And this is associated with a fracture of the auditory canal and lower areas of the skull. So again, the base of the skull is sitting right down here. And this area here with all the air cells and things that are in it, make it relatively easy to fracture there. So that's, you may see Battle signs with a basilar skull fracture. The other thing you can see is raccoon eyes, and this is just bilateral periorbital ecchymosis, black eyes forming around the eyes, which sometimes is associated with orbital fractures as well. So again, this is Battle signs and raccoon eyes you can see with basilar skull fracture. The other thing you can see is, that CSF may be leaking out of the fracture. Because of again, I showed you the inside of the skull. It's pretty rough and sharp in there, and it may actually tear the dura if there's a fracture or there's a fracture line through that part of the skull. And it can permit spinal fluid to drain out. You may, of course, there's probably going to be bleeding associated with it. So sometimes the spinal fluid may mix with blood, and you have to do what this person is doing here on the gauze is what we call either the target sign or the halo sign. If you sort of dab some blood on the gauze, and then the blood kind of settles where it's going to be, but then this spinal fluid will continue to seep into the gauze and cause, again, what we either call the target or a halo sign. And again, that's indicative of a spinal fluid leak from basilar skull fracture. All right, so brain injury, as defined by the National Head Injury Foundation, and I'll just read it, is a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes. Certainly some emotional and vocational changes happened with Phineas in the beginning there when we talked about him. So they can be classified as either direct injury or primary injury, and then there's indirect or secondary injury, and we'll talk about that as well. So the primary injury is the damage to the brain from the biomechanical effects of the trauma. So that's the direct injury that happens to the brain, during the trauma. The secondary injury is a result of hypotension, hypoxia, and the elevated intracranial pressure. And that's where we can probably intervene the most. So direct brain injuries, there's the coup and contra coup. I'm sure you've heard of. The coup is the injury at the site of impact. The contra coup is on the opposite side because you have a sort of a shearing force going on. And I think it's probably best seen, when you look at this video. You can see that the coup, the coup injury is in the front and it gets whacked in the front, and then the brain bounces off the back, and you have the coup contra coup injury. So again, this is what causes brain injury. So you can have different types of injury categories. There's either focal or diffuse. Focal sort of defines, it happened in a specific location, and there's damage there. And differentials of that, and we'll talk about, is cerebral contusion, intracranial hemorrhage, and then intracerebral hemorrhage. Again, these are focal injuries, whereas the more diffuse injuries are things like concussion and diffuse axonal injury. So cerebral contusion is any blunt trauma to the local brain tissue. It's essentially a brain bruise, right? So capillary bleeding into the brain tissue. It's common with blunt head trauma. You may get a little confusion You may get a little bit of neurologic deficit, some personality changes, vision changes, speech changes, again, depending on where in the brain you get hit, where it's caused the contusion. And again, this is one of the injuries that results from the coup contre coup. So you can imagine that brain bouncing around inside the skull is going to be bruised, and that's a cerebral contusion. When we talk about the intracranial hemorrhages, that's bleeding that occurs within the cranium, within the skull. First is an epidural hematoma. Again, this is in that epidural space, so it's outside the dura, so it's bleeding between the dura and the skull. And what happens is that an artery is usually injured. Most commonly, it's the middle meningeal artery, and then there's bleeding into that potential space that's the epidural space. The middle meningeal artery runs under the temporal bone on the side of the head, and that's why it's the artery that's most commonly involved, because the temporal bone is thin and the artery is very close to the surface there. You get rapid bleeding. Again, it's arterial bleeding, and then, of course, a reduction of oxygen to the tissues. What happens is, again, there's not a lot of space in the skull, so as the bleeding continues and forces the brain to sort of displace, and then it eventually herniates down towards the foramen magnum, and that's obviously a problem. If you look at a CT, this is what an epidural hematoma will look like, or will look like. It's sort of a lens shape, if you will, because of the defining dura on one side, and it just kind of contains the bleeding, under or outside the dura in a, what we call like a lens shape. So again, this is an epidural hematoma. Certainly the treatment is to evacuate that, so that, the neurosurgeons can put a hole and get the blood out that way. This is a subdural hematoma. Now, this is blood that is occurring under the dura, so under the dura and in the the arachnoid space, and it's bleeding within the meninges. And this is more of a slow bleed. This is usually a venous type bleed, like from the superior sagittal sinus, one of the big, venous vessels in the brain. And this one certainly can happen suddenly, but sometimes may progress over several days because it is such a slow bleed, and you may get a slow deterioration of mentation. Somebody hits their head or has a fall, and then over the next couple of days kind of deteriorates. This may be the findings of a subdural hematoma. And again, this is what a subdural looks like on CAT scan, and you can see the blood is over here, the white stuff that's over here, and you can see that's kind of less defined than the, sort of the lens shape of the epidural hematoma. This is a subdural, and you can see what it's doing to the brain. It's causing the brain to shift over. So this would be the midline of the brain. It's causing the brain to shift. So again, this is a problem. Treatment, same thing. If it's significant enough, you want to, you're going to intervene there by, evacuating the blood that's occurring, that's accumulating on the side of the brain. Intracranial hemorrhage, or in this case, an intracerebral hemorrhage, is blood within the brain tissue itself. And these are difficult to fix because you can't really get the blood out as you can with an epidural or subdural hematoma. So this is usually from a ruptured blood vessel within the brain tissue itself. This is essentially like a hemorrhagic stroke, or actually is a hemorrhagic stroke. And again, when we talk about stroke next month, it'll be, one of the hemorrhagic strokes is an intracerebral hemorrhage. And of course, signs and symptoms worsen over time. The more bleeding that happens, the more edema you get, and the more chance for herniation, et cetera. So that's an intracerebral hemorrhage. Diffuse brain injury, again, this is because of a stretching force is placed on the axon. So this is, the whole brain kind of shifts, and all of the axons are stretched to their limit, and the pathology is distributed throughout the brain. Again, this is not a focal injury. This is a diffuse injury, and this is when we talk about things like concussion and diffuse axonal injury. So first, concussion. Concussion is a mild form of diffuse axonal injury. It's nerve dysfunction without anatomic damage, and it's typically a transient episode of confusion, disorientation. You get a little bit of amnesia. You don't remember what happened. There might be repetitive questioning, things like that. And you certainly should suspect it if a patient has a momentary loss of consciousness. You know, if there's a head injury and they're knocked out for a short time, then this is, you know, typically a concussion until proven otherwise. Management, you just kind of, you know, frequently reassess mentation to make sure that they're not getting worse. And as always, ABCs. This is from the Massachusetts Concussion Management Coalition. Again, you know, when we work with athletes in athletics, you know, certainly concussion is a sort of a hot topic now, right? It's a you know, it's been recognized in the NFL, and it's been recognized to cause some problems later on. And certainly, again, one of these, you know, sort of hot topic, everybody's talking about concussion. And certainly concussion can be its own, you know, rounds or lecture, you know, in and of itself. But just to mention a little bit about concussion, because it's something we are going to see or certainly have seen. And again, it's a functional injury. It's not a structural injury. So imaging is not recommended. So, you know, if you get a CAT scan or a standard MRI, you're not going to see a concussion. There's nothing that's going to show. Again, this is a diffuse axonal injury, and this is more of a functional injury. And really, the diagnosis of concussion comes from the symptoms. And the symptoms can be, you know, certainly many cognitive, physical, problems with sleep, emotional things could be happening. And, you know, the list is sort of, you know, pretty extensive for concussion symptoms. You know, typically people come in with headaches, sometimes vision disturbances, they're dizzy, they're vomiting, confused, you know, can't remember things, they're sensitive to light, sensitive to sound. They have this, you know, repetitive questioning, the last, you know, what happened, you know, over and over and over, because they can't remember the answers to the question. So again, you know, concussion diagnosis is made pretty much from these symptoms and certainly not from imaging. Some facts, again, this is from the Concussion Management Coalition. It's a short-term impairment of neural function and again, this constellation of symptoms. It's not visible on standard CAT scan or MRI. There are, you know, special MRIs that can be done that show concussion, but certainly not something that's done, you know, in the emergency room or on a sort of a case-by-case basis. You know, the prevalence estimates, again, just like head injury, they're difficult because most people don't seek medical attention. You know, you may be playing sports with friends or something and hit your head and have a concussion, and you may not seek medical attention. So we don't know how often this is occurring. You know, we know when people come, obviously, but we think that about a third of concussions still go unreported because of the nature of how it happens. So again, this is out of the CDC. This is more current data. 3.8 million concussions occur from sports and physical activity, and this is the concussion rates, you know, per 100,000 athletic exposures. And certainly football is right up there with the, you know, the most concussions. But you can see all the sports are represented, even cheerleading on the bottom. You know, you can get, you know, you fall off the pile or snap your neck or something, you get concussion there. It's not just sports. And again, just like brain injuries, you know, MVAs certainly are the, you know, very common. You can get struck in the head or you fall. Again, these are all reasons for concussion. Post-concussive syndrome, and again, we've probably all seen people with a post-concussive syndrome. They hit their head and they're still having problems with memory or concentration or you know, headaches, dizzy, you know, can't sleep kind of thing. And this may actually last for weeks or months after a concussion. And certainly the most important thing that we can do is to tell them to avoid activities that will put them at risk for a repeated concussion. Because certainly, you know, the more concussions that start to add up, that's when you end up with long-term problems from concussion. So again, you know, not a lot to do emergently, but certainly to avoid other activities that could cause concussion. Moderate diffuse axonal injury. Again, this is you know, something that has been termed classic concussion. Again, same kind of mechanism. This is if, you know, you may be unconscious if you know, for a short time. This may exist with a basilar skull fracture. Again, this is a diffuse brain injury where the whole brain is involved, the head is involved. And you can see, again, the signs and symptoms are essentially the same here as well. A severe diffuse axonal injury, this may result in a brainstem injury, which could be catastrophic. So this has a higher mortality rate. This is when there's just mechanical disruption of the axon. So there's enough of a head injury that you've disrupted the communication with axons. This may be someone who's unconscious for a longer time. Cushing's reflex, which we'll talk about in a second. And this is where you may actually see posturing, either decorticate or decerebrate posturing. So just to review, the intracranial space, the cranial volume is fixed, right? Whatever is in the skull is fixed. There's not a lot of room for movement there. So about 80% of the space is filled with the brain itself, right? The cerebrum, cerebellum, brainstem. About 12% is some additional blood vessels, and of course the blood that's in the blood vessels. And then about 8% of that space is filled with spinal fluid. And again, it's a fixed volume. So if there's an increase in the size of one component, then it diminishes the size of another. So obviously there's a fine balance of what goes on there in the cranial space. And certainly any increase will cause an increased intracranial pressure. So this is Cushing's reflex, and we'll talk about this in more about the definition here. But if the mean arterial pressure is less than the intracranial pressure, it means that you can't get blood flow to the brain because the blood pressure isn't high enough to overcome the intracranial pressure, then the hypothalamus activates sympathetic nervous system, and that's your fight or flight mechanism. And we know what happens there, right? Adrenaline is released, and we get vasoconstriction, increased cardiac output, increased blood pressure. But then there are baroreceptors in the carotid body sense this high blood pressure, and they slow the heart rate. So what happens in Cushing's reflex, if you have intracranial pressure increasing, the blood pressure goes up and the pulse rate goes down. So you'll see somebody with an increased blood pressure, but a slower heart rate, a reflexive slower heart rate. And this is called Cushing's reflex. Cushing's triad is if you add those two things and then add the Cheyne-Stokes respirations or the irregular respirations. So somebody with a severe head injury is going to have a higher blood pressure because they're trying to pump blood against the gradient. They have a lower pulse because they're responding to the high blood pressure. And then they may have Cheyne-Stokes respirations or certainly abnormal respirations. Okay, so this is the impetus for this pre-hospital management of traumatic brain injury. This was a course that was developed by the Brain Trauma Foundation several years ago. So it's a little bit dated, but really nothing much has changed because brains are the same and blood pressure is the same and all that. So really not a lot has changed over time, but it's really to enhance our knowledge of anatomy, physiology, and treatment of head injuries. And of course, that's what we're here to talk about. And the 90-99, right? The big mystery of what 90-99 is. I'm sure some people have figured it out, but we got to throw a little mystery into these rounds because we know the topic ahead of time. So we need something that's a little bit mysterious, if you will. So the assessment objectives, we're going to describe the signs and symptoms of hypoxia in brain injury, how we measure the pulse ox, and you all know that, and then the effects of hypotension on the brain injured patient. We're going to talk about the GCS score a little more. Again, we kind of introduced the Glasgow-Coma scale. We're going to name a score that indicates a severe brain injury, differentiate between flexor or decorticate and extensor or decerebrate posturing. We'll talk about the pupil exam and pre-hospital signs of herniation. So just some definitions. Again, I know you all know this stuff, but oxygenation is delivery of oxygen. Hypoxia means the level of oxygen is decreased. Oxygen saturation, is the percentage of hemoglobin that's saturated with oxygen. We measure that with pulse oximetry. And then of course, ventilation is movement of air in and out of the lungs. So when we talk about brain injuries, like with anything else, airway comes first, ABCs, so airway, and certainly with somebody who's brain injured, you want to maintain C-spine precautions because of the possibility of a cervical spine injury as well. So make sure the airway is open, assess the need for artificial airway, and again, assess and reassess every 5 minutes or so. Breathing, same kind. This is stuff we all know with ABCs: rate, depth, quality of breathing, and again, assess, reassess every 5 minutes. Hypoxia occurs in 40% of severe brain injured patients. So again, this is what we want to look out for. This is the secondary injury that comes from brain injury. So hypoxia is quite common in brain injury. So we're going to assess for hypoxia. I think we all know how to use pulse oximetry, especially after this year that we've been through, where people were buying their own pulse ox machines. So again, pulse oximetry is a good way to measure oxygen level for hypoxia. C for circulation for hypotension. Look for signs of shock. Again, assess and reassess the systolic blood pressure every 5 minutes or so. The adult critical threshold level is 90. So there's one of your 90. So 90 millimeters of mercury is the critical threshold for blood pressure for someone with head injury. Of course, kids and infants are going to be lower because of their, innate lower blood pressures, and certainly using an age-appropriate cuff. So again, systolic blood pressure thresholds, hypotension should be considered according to age groups, and you can see here. Again, I would have to look these numbers up. I certainly don't memorize things like this, but just to know that adult hypotension, when we see an adult with a brain injury, systolic blood pressure less than 90 is considered hypotension. All right, so I did talk about mean arterial pressure already, and this is how you calculate mean arterial pressure. It's the systolic plus the 2 times the diastolic over 3. And again, this is not to make you do math, but just to know that the mean arterial pressure is sort of somewhere between the systolic and diastolics. And a lot of the newer machines now will give you the mean arterial pressure right on the machine. So again, not to force any math, but just to say that the cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure is the cerebral perfusion pressure. So in other words, the blood pressure that's pumping into the brain and that has to overcome the pressure that's within the brain and the skull to get perfusion to the brain. So you can see here that as an example, the mean arterial pressure is 70, ICP is 30, then the CPP is going to be 40. The important thing to remember is that the CPP of 60 is the critical minimum threshold. So you have to have, the mean arterial pressure has to be at least 60 above the ICP to get any blood flow to the brain. So the take-home message here is that maintaining blood pressure is critical. So it's critical, again, that the patient not be hypotensive and that the mean arterial pressure is enough to get over the ICP. So can you measure ICP? Yes, you can. Certainly we don't, but you can put a catheter right into the ventricles of the brain, and then you'll get an ICP reading. You see here the ICP reading is 19 on this monitor. And again, I told you that the blood pressure, the mean arterial pressure kind of prints out. This is the mean arterial pressure is 79. So mean arterial pressure minus ICP 79 minus 19 is 60. So the CPP is 60. So that's the minimum critical threshold. So again, the take-home message is that not to let somebody be hypotensive. So ABC, D is the level of consciousness, and the level of consciousness is certainly an important predictor of how bad a brain injury is. And this is where the Glasgow Coma Scale comes in. So the Glasgow Coma Scale is a reproducible measure of level of consciousness. And the important thing is that you have to assess it every 5 minutes. So you continue to reassess the Glasgow Coma Scale. A deterioration by 2 or more points is certainly significant and an indicator for morbidity or mortality. The good thing about the Glasgow Coma Scale is that it's something that we all know, and that it's a way for us to communicate. And that's why it's reproducible, so that you know what a Glasgow Coma Scale of 15 is. I know what a Glasgow Coma Scale of 15 is, and certainly if it's decreasing by 2 or more points, that's significant for both of us. So you use it after your initial assessment. You use it after the ABCs. Obviously, that's much more important, and you certainly want to use it prior to any sedation or muscle relaxants, because that's going to alter your ability to have a motor response. So that's how we're using the Glasgow Coma Scale. Again, this is the Glasgow Coma Scale. Again, like I said, I don't have it memorized. I would have to look each time. So you look at the best eye-opening response, verbal response, and motor response, and you can see that, and then you get a total. And again, 15 is perfect, 3 is not so good. So Glasgow-Coma scale indicators of brain injury severity, 14 to 15 is a mild brain injury, 9 to 13 is moderate. Anything below 9, anything less than 9 is a severe brain injury. So Glasgow-Coma scale of 3 to 8 is severe brain injury. So that's where the 9 comes from. So again, the Glasgow-Coma scale has been studied and is reliable. It's the most widely employed method for reporting serial neurologic evaluations. Again, it's done, every 5 minutes or so. It's a good indicator of level of consciousness, head injury severity, and it's reliable because we know, again, we all communicate with the same sort of language, if you will. The thing is that a single field measurement of GCS can't predict outcome. So if you tell me the Glasgow-Coma scale is 15, that's great, but that doesn't really mean anything, especially if the next one you do is 10, right? So the important thing about this is that we do it and then continue to do it, reassess, reassess, reassess. So, and here was a study that showed that a decline of Glasgow-Coma scale over time can certainly be indicative of need for acute management and, certainly mortality. So you can see that if the field GCS is 7.2 and in the ED it's 7.2. Now this is a pretty bad Glasgow-Coma scale, but the mortality is at 20%. Whereas if it drops almost 2 points, 8.4 to 6.7, you can see the mortality is clearly worse. So any drop certainly of a 2 points or more is certainly indicative of a worsening brain injury. Pupil response, we talked a little bit about pupils before, but again, the importance of assessing and then reassessing. You want to look at pupil size, symmetry, whether or not they react to light, right? So bilateral symmetry. Again, we talked about a blown pupil if one is clearly larger than the other. And again, if patients can participate, you can ask them if they normally have abnormal pupils. Whether or not they react to light is certainly, again, that's testing the oculomotor nerve. And then if they're dilated, again, if they're, either one or both are dilated, can be an issue as well. So this is, research has found that, a single fixed and dilated pupil, again, a blown pupil, as we call it, 45% poor outcome, whereas bilateral fixed and dilated pupils, 82% poor outcome. So again, the pupils tell us a lot about, the sort of the predictability of what's to come. Pupil abnormalities, are there things that can mimic pupil abnormalities? Of course there are. It may not be a brain injury, could simply be hypoxia, hypothermia, orbital trauma. Somebody could have got, in the process of having a brain injury, could have got hit in the eye, and the eye is dilated because of, eye trauma specifically. Pharmacologic treatment, of course, things like atropine, those medications and things that dilate the pupils. Cataract surgeries, older folks who have had cataract surgery, have a non-reactive pupil now because there's an artificial lens that's in there. Hypertension, illegal drug use, of course, can mess with the pupils. Toxic exposures, again, the pharmacologic toxic stuff. An artificial eye, don't forget about people with prosthetic eyes. A little bit of a funny story. I have an uncle that has a prosthetic eye, and he had a syncopal event at home. And when the EMS came, my aunt said to them, he kept staring at me. He kept staring at me, and they, insisted that he had a seizure because his eye was open. Well, he has a fake eye, so that eye is always going to be open and staring. So again, if you know this about someone, certainly is important. Congenital abnormalities, again, or anisocoria, some people have irregular pupils at baseline. So again, there's things to know about as well. The blown pupil we talked about suggests herniation because it's compression of the brainstem on one side. It's compressing the oculomotor nerve on that side, and it makes the pupil not reactive to light, and it's so it just dilates, and it's what we call a blown pupil. It's indicative of a same side mass, again, so it's happening on whatever side the herniation is happening on. And of course, we're going to treat for increased intracranial pressure, hypoxia, and hypotension if we see a blown pupil because we know there's a head injury. So what are some other indicators of herniation? How do we know that somebody's gotten to the point where the brain is swelling and it's starting to herniate through the foramen magnum? Well, certainly the patient is unresponsive or comatose, and with two things. So they either have an asymmetric pupil, a blown pupil, or bilateral dilated unresponsive pupils. So either one or both pupils are dilated, and they have abnormal extension or decerebrate posturing or no motor response at all. And if you look at the Glasgow Coma Scale, these are, under the motor response, this is a 1 or a 2. So, 1, of course, means no motor response at all. Decerebrate and we're trying to get away from the terms decorticate and decerebrate because people sometimes don't remember which is which. So if you remember that decerebrate is an abnormal extension, so that, the arms are extended. Decorticate is abnormal flexion, and decerebrate is abnormal extension. So the posturing here is abnormal extension. So somebody who's unresponsive, comatose, dilated one or both pupils, and abnormal extension or no motor response, these are all indicators of herniation. So the take-home messages here, again, ABCs are important. The GCS, we talked about how that's important. Herniation, when to suspect herniation by the pupil and motor exam, and the thresholds of 90, 90, and 9. So 90 systolic, 90 pulse ox, and then 9 is the Glasgow Coma Scale, which indicates a severe head injury. Use assessment to determine treatment. So what is treatment? Let's talk a little bit about treatment. So our treatment objectives are to talk about normal and hyperventilation rates. We can hyperventilate folks with herniation or brain injury. And then, we're talking about hypotension. So what's the proper fluid resuscitation for people with brain injury? And what can we do if we suspect that the brain is herniating? Well, again, airway and with attention to C-spine, airway support per your scope of practice, whether you're able to intubate or not, et cetera. You correct hypoxia. And again, make sure you're considering C-spine or facial traumas. When should you intubate? Again, Glasgow Coma Scale less than 9 is a severe brain injury, and these are people that need airway intervention. So GCS less than 9 should be intubated. Breathing, again, rate, depth, quality, effectiveness, oxygen, the appropriate ventilation rates for age and herniation. Again, this was an older study, but again, showed the importance of pulse ox. Pulse ox at the scene of the accident, greater than 90%, you see mortality, 14%. As the pulse ox drops, the mortality increases. So again, the importance of keeping the pulse ox at least above 90% to decrease mortality and morbidity with head injury. Capnography is certainly a good thing to use, and certainly is getting more use nowadays. Capnography is indicated, obviously, for somebody who's intubated. The protocols to put somebody on end-tidal CO2 capnography to confirm tube placement, et cetera. But certainly when you're going to hyperventilate somebody, we can aim at an actual CO2 number, an end-tidal CO2 number around 35. So we are not just guessing at how much we're hyperventilating somebody. We're going to actually have a target number to do it with. So normal ventilation rates, if the approximate normal ventilation rates, you can see here for an adult, child, and infant, and it says 10 breaths per minute for an adult. I guarantee if you go to the ER and you look at any chart right now that says the respiration rate for the patients is going to say anywhere from 18 to 20. And certainly we don't breathe that fast. If you just kind of measure your own breaths per minute when you're at rest, it's probably closer to 10 or so. So really, so a normal ventilation rate for an adult is about 10, and then hyperventilation is double that, or about 20. So this is when we're gonna hyperventilate people for brain injury. Again, we're just gonna kind of double it. Certainly using end-tidal CO2 is the best way to do it to maintain PCO2 of 35. So again, take-home messages here. Hypoxia increases morbidity and mortality. Evidence defines hypoxia as an oxygen level less than 90. So again, that's one of the 90s. Intubating unconscious and unresponsive brain injury patients improves outcome. Again, we're intubating with a Glasgow Coma scale less than 9. Treat the hypotension, maintain a systolic blood pressure greater than 90 in adults. You know, you'd have to look, it's lower for, of course, for infants and children, and use isotonic fluids when resuscitating people for hypotension. Again, there have been lots of studies, and again, these are older studies, but really not much has changed. So lots of studies that show that, you know, the secondary injury that we're talking about from hypoxia, hypotension, can certainly be eliminated if we pay attention to it. All right, take-home messages here. Evidence defines hypotension as a single observation of systolic blood pressure less than 90. So in other words, if you're on the scene and you get one blood pressure that's less than 90, all the rest of them are good, that is still considered hypotension and still requires fluid resuscitation. So even one reading less than 90 is significant because it doubles morbidity and mortality. So again, one reading of 90 or below. So the goal is to maintain 90 or above. Some other things that we can do, brain targeted therapy, and you hear about this stuff, not only with trauma, but with stroke, certainly. Glucose only for people who are hypoglycemic. You want to avoid glucose containing, you know, IV fluids, you know, like even D5 or something like that. So glucose only if you need it for hypoglycemia. Certainly sedatives for agitation, people who are injured or brain injured and they become agitated, certainly that increases their intracranial pressure. So think about sedating them or certainly giving them analgesics. So analgesic sedatives for, you know, to relieve some of the anxiety and agitation associated with it. Paralytics for intubation, of course. I mean, you know, again, you don't want to be trying to intubate somebody awake, and certainly would cause an increased intracranial pressure if that were to happen. Some of the things that come in and out of play are things like mannitol. You know, mannitol is a sugar that we can give, and it's thought to reduce brain swelling. Again, this comes in and out of favor. I think it's in right now. I think we're using mannitol again, but again, that kind of goes back and forth. Lidocaine, they say they give lidocaine before you intubate somebody. There have been no studies that ever suggested that does anything, but you know, that's one of the things that we've done forever. So, you know, to give lidocaine before you intubate somebody with a head injury. And then hypertonic saline, again, it comes in and out of controversy, but certainly is not in use right now for this cause. What are some other factors that can affect intracranial pressure? Well, we talked about the anxiety, fear, pain, vomiting, straining. So if somebody, again, if you have somebody with a head injury who appears to be in pain or agitated, you can certainly medicate them for that. Vomiting, you can certainly give them, you know, something like Zofran to prevent them from vomiting, because that's gonna increase their intracranial pressure. Environmental stimulation, you know, you keep things quiet and you know, low lighting, et cetera, et cetera. And of course, intubation and suctioning are going to, again, if they're not sedated, it's going to cause some increased intracranial pressure. Again, nothing's really been studied to show, you know, just how much it happens, but it certainly is something to consider when you're dealing with these patients. All right, take-home messages here. Again, ABCs, airway and intubation, oxygenation, blood pressure, hyperventilate when indicated, glucose, again, only when appropriate, and then sedatives and analgesics if you need them. Okay, so finally, where are we going with these people? And, you know, we've assessed them, we've treated them, and now, you know, where do we transport them? So these are the protocols. These are the, you know, Rhode Island protocols. And you see the one on the left is the head trauma or traumatic brain injury protocol. The one on the right is an acute neurologic event with evidence of increased intracranial pressure. Again, that, you know, that kind of fits in with this talk as well. The thing I want to point out though is this point here. Patients taking anticoagulants and antiplatelet agents with altered mental status following a fall should be transported to an age-appropriate level 1 trauma center. So a lot of times we hear about people who are on, Plavix or Coumadin or something like that, and they get and they fall, fall from standing, whatever, and they get transported to the trauma center. They only need to go to the trauma center if they have an altered mental status, and that says that clearly here. So, if somebody's on Plavix or Coumadin and they, fall from standing and they're not altered, they do not need to go to a level 1 trauma center. So just kind of keep that in mind. But again, these are the protocols as they are for brain injury and increased intracranial pressure. And really what we want to do is, dispatch the appropriate EMS personnel, obviously, if it's somebody who needs intubation, et cetera, use what we learned here in the state, regional, local protocols. Again, we have great protocols that include all of this stuff, and I'll show you what I mean in a minute. And then transport to the appropriate receiving facility based on the injury, Glasgow Coma Scale, and pupil response. So again, if you think somebody has a severe brain injury and they meet criteria for a trauma center, then certainly that's appropriate. If not, then the closest hospital is appropriate. So of course, take-home messages, clinical practice should be evidence-based, and certainly we talked about some of the evidence, even though it's a little bit older again, but not much has really changed here. The importance of doing early and repeated neuro assessments, not just one exam, repeat it every 5 minutes or so. We're going to identify patients with severe brain injury, and that's a GCS less than 9. Avoid hypoxemia, and that's to keep the SATs above 90. Avoid hypotension, keep the systolic blood pressure above 90. Again, so this is your 90, 90, and 9. That's really the important take-home point. Hyperventilate when we suspect that there are signs of herniation. Again, that's a blown or dilated pupils with posturing or no movement at all. And then triage and transport to the appropriate facility based on severity and certainly based on our protocols. Again, in summary, the importance of a good neuro exam. We went over the neuro exam kind of briefly in the beginning. Certainly you can spend hours just talking about our neuro exam. And then, we talked about brain trauma. So really the take-home point, avoid the H-bombs. And it's kind of ironic that last month we talked about the H's and T's, and here we are talking about H's again. So avoid the H-bombs here. Hypoxia, keep the SpO2 greater than 90. Hypotension, keep systolic blood pressure greater than 90. Hyperventilate when there's evidence of herniation, blown pupils, and no motor response or posturing. And we can hyperventilate to a end-tidal CO2 of 35, especially now we can use capnography to measure that. And then hyperglycemia, you'll only want to use glucose when someone is hypoglycemic. So again, avoid these H-bombs. And if you don't remember it from this lecture, all of these H-bombs are on the protocols. So again, like I said, these protocols are well done, and right in response to this Brain Foundation course or findings, and certainly all of the things that you need to remember are in the pearls of the protocols. Don't forget about trauma to the spinal cord, and again, that's a whole separate lecture we can talk about. But remember spinal motion restriction precautions, especially with somebody with a brain injury. They certainly could have cervical injury, and then 90, 90, and 9 is the real take-home point from this whole thing. So does anyone have any questions? You can certainly unmute yourself and ask, or you could share them in chat, but I'd be happy to entertain any questions or comments. Again, I leave my email. If you think of something after, or you have an idea for rounds, or you want to tell me something about EMS handoffs or something like that, again, feel free to use this email and contact me. You can also, I'm sure I'll throw Eileen into this, but you have Eileen's email from the flyer. You can certainly get to excuse me, get to me through her as well. Again, in June 9th is the second Wednesday. We're going to talk about stroke as per our review for Charter Care. July 14th, I've kept open. I was planning to do pre-hospital care of exertional heat stroke in June, but we can bump that to July. Again, pending, somebody else may have something more pressing, but certainly we have a schedule going forward, and we'll try to keep up with that. So if anybody has any questions, I'd be happy to answer now. Or like I said, you can certainly email me. So thanks all for participating. And if you have no questions or no other comments, you're certainly feel free to sign off, and we will see you next month. I'm going to stick around in case anybody has questions.
Would you like me to stop recording?
Oh, please, yes.
Okay.
You have that